what's your breathing like? And it's subjective from the point of view of the patient. So it's going to be different for a smoker than it will be for somebody who doesn't smoke. With orthopnea, this is when a person is laying down. So if you see ortho in front of it, it usually has something to do with an elevation change. So in this case, when somebody is laying in a prone position, they feel that their breathing is different. Okay? And then you have paroxysmal nocturnal dyspnea. This is when a person stops breathing and they wake up gasping for breath, which is different than sleep apnea, which we'll talk about later. All right, so in terms of different types of disorders, pulmonary disorders, there's the cough, and there are two types. There's acute and chronic. And if you know anybody who has been a long-time smoker, you know the difference between that chronic cough and an acute cough that's associated with an upper respiratory or lower respiratory condition. Okay. So in this particular case, you're going to look at what type of cough, how long have you had it, what does the cough sound like, what types of muscles are associated with that cough. Okay. So is it the intercostals or is it just diaphragmatic? Okay. Is it abdominals that are associated with it, or is it specifically just more superficial? With abnormal sputum, in this case, you're going to find out whether it's viscous, if it's mucousy, if it's green, pussy, what type of conditions are associated with that sputum for that particular patient. Okay, so hemoptysis. What is that associated with? What is hemo? What do you think? Blood. So are they coughing up blood? So in this particular case, is there something that's associated with either an inflammation of the bronchial airways that causes abrasion and the patient's coughing up just sort of reddish coloration, or is it clots of blood? So those types of things are going to be helpful in your diagnosis. The other thing is sometimes the patients have a lot of foresight and they actually bring samples in so you can look at them, and that can help. With cuspal respirations, these are breathing patterns not associated with characteristics within either the sputum or the blood associated with that. So with abnormal breathing patterns, cuspal is hyperpnea. So they have this high, and they have very shallow, fast breathing. With Cheyne-Stokes respirations, in this case, this is where they have this fast breathing, and that fast breathing becomes deeper to the point that they almost hyperventilate, and then they stop breathing for a little bit. So it's, and then they stop breathing, they get apnea. So what I recommend you do is go to YouTube and plug these in, because you'll actually see a patient that has these types of symptoms and get a feel for what these look like and sound like. And also get a feel for what's happening with the patient's chest muscles. So when we're thinking about different symptoms, hypoventilation comes into play. Because hypoventilation means, of course, that there's very slow breathing, or breathing that is not meeting the needs of the person, oxygen consumption. With that is accompanied hypercapnia. And hypercapnia is increase in carbon dioxide. So when you're reading about this in your book, you'll notice that it has a C in it. That's how you can always remember that it's associated with carbon dioxide. Okay? Hypoventilation is air in and out. So you have the upper airway going into the alveolar spaces. So in and out, just like a fan, in and out. And then once it gets to the level of the alveoli, that's where you have that gas exchange and you have a buildup of hypercapnia in the lower portions of the lungs, and you have increase in carbon dioxide. It's not getting ventilated well. Okay? With hyperventilation, you have the opposite. You have very strong exchange of gas through the bronchial airways, but you have no buildup of, or lower buildup of carbon dioxide. And when you're talking about what drives respiration, it's carbon dioxide. Okay? That's what drives respiratory rates, not oxygen. Even when an athlete is at peak activity and they go into oxygen debt, it's because of the increase with carbon dioxide output that's causing that increase in respiratory rate. Okay. So, if you have hypoventilation, you have buildup of carbon dioxide. If you have hyperventilation, you have a lack of carbon dioxide. So, if you do that, holding your breath to go across a swimming pool, see how far you can go underwater. Usually you want to try to get very close to hyperventilating because you reduce the carbon dioxide and you reduce the need to take the breath so you can go longer. You are all familiar with cyanosis and you should be familiar with clubbing. So blue coloration because of an increase in carbon dioxide and a decrease in oxygenated blood, high oxygen blood. Clubbing is associated with what? The fingers, digits. And the shape of the digits because of poor circulation. And whether or not there's pain associated with ventilation. So we've talked a little bit about clubbing, especially when we have problems with cardiovascular, and you can have the patient hold their fingers together like this and see whether or not they have that little window in between their nail beds. If they don't, then they have different degrees of clubbing. And that's indicative of poor circulation. Now, if a patient has hypercapnia, then they're going to have a problem with lack of oxygen in the blood. Okay? They have a buildup of carbon dioxide, which means they have hypoxemia. And the difference between hypoxemia and hypoxia is that hypoxemia is in the blood. Okay? It's in circulation. There's low oxygen in circulation. So you put the little oxygen monitor on the finger, it's going to be lower than 95. Okay? So especially if you work with patients that come out of surgery, one of the things that the recovery nurses do is say, take deep breaths, and then you remind your saying, well, swear words at them, let me sleep. But the problem is that if you could see the monitor as a patient, you'd see that the oxygen concentration could be very low. It could be low 90s, it could be in the 80s. Okay? So take those deep breaths to increase oxygen in blood. Okay? With hypoxia, that's in the tissues. So you have low oxygen in tissues, and that is going to lead to problems with acidosis. So one of the things that is very strongly related is this relationship between ventilation, pushing air in and out of your lungs, and perfusion, which is the circulation of the oxygen throughout your body. Okay? And so there are ventilation perfusion abnormalities that can cause hypoxemia. Okay? And one of them is shunting. And we'll look at different types of shunts that occur within the structure of the lungs itself. Okay? So we talked about different types of abnormalities in the heart, especially with the fetal part. We'll see some in terms of lungs. And then acute respiratory failure, basically, there's nothing. So in this case, the book talks about ventilation and perfusion. So obviously blue is low oxygen and red is high oxygen. So in this case, ventilation is always associated with a V with a dot on it, and then the Q is the perfusion with the dot over it. And this is the normal condition. So from the pulmonary arteries that are going to bring the blood that needs to be oxygenated to the lungs, it brings in that blood, and you have ventilation occurring in the upper portion of the airway, and then you get this exchange of oxygen in and carbon dioxide out. Then, after it's been oxygenated, it goes to the pulmonary veins and back to the lung. If there's low ventilation perfusion ratios, then you're getting impaired ventilation, and here you can see this occlusion. And all of you should know the definition of an occlusion. So in this case, you have ventilation, but it can't get into the alveolar space where the actual exchange occurs. So here you have normal alveolar space, and you can see half low oxygen, half high oxygen, and then it goes back. But in this one, since it's occluded, you can't have that ventilation that fully inflates the alveolar space, and so you get this impaired ventilation that the consequence of it is you get low oxygen blood and you get hypoxemia. If you have a shunt, in this particular case, you can see that you have blocked ventilation and there is no alveolus that inflates at this point. So here you have this shunt. But the problem is, since the alveolus is not, you have this is from the airway, and it's totally occluded, and then you have this, you can see the increase in the size of this particular portion of the pulmonary artery. So you have the same effect. You have full occlusion, and then you have hypoxemia, but the hypoxemia is more extreme in this case. And then if you have high ventilation perfusion ratio, then in this case, you can see the difference in this pulmonary artery and how thin it is. You have this alveolar dead space, and there's a difference within the, you can see this is more, no, it's not smaller, it's more, when you blow the air in the balloon, inflated. Thank you. It's more inflated. Okay, so you can see, okay, so yes, the capillary around it, it looks smaller. Okay, so if that's what you're referring to, absolutely right. So the alveolar space has greater inflation, and so there's more pressure in there. And the problem is, because this is smaller and there is impaired perfusion, you're not getting that oxygenated return. Okay? So these cases, these two are very similar. This is a greater severity. In this case, you have a problem because of the pressure. So air getting into and out of the lungs is ventilation. Getting oxygen and carbon dioxide exchange across the respiratory epithelium is where you're getting really important changes in pressure that we'll talk about later. But when you're looking at chest wall disorders, you're looking at the importance of pressure, because when you take a deep breath, that deep breath causes your lungs to expand. And when your lungs expand, your rib cage opens up. And your lungs are attached to your rib cage. So when the diaphragm contracts and moves down, it's going to pull that muscle is going to go down, and it's going to cause a bigger cavity. And then your intercostal muscles are going to expand your ribs. And when that happens, you get a big void, and air rushes in. Okay? So if there's any problem with the chest wall, then you lose the ability for your muscles and your lungs to there's this compromised chest wall. It can be from some type of deformation, a problem with immobilization, which you see in your geriatric patients because they don't want to take deep breaths. It hurts because of arthritic changes. And with obesity because of the compression on those lungs. So when you look at flail chest is an instability in a portion of that chest wall. So there are different ways that flail chest can occur. Okay? So in this case, you have air moving in. Okay? So this is normal. Okay? Then and you can see that the diaphragm is going to contract and it moves down and it opens up the lungs. So there's greater surface area in the lungs. And when you relax and you breathe out, then those muscles contract and they push the air out. If you have flail chest, in this case, the chest wall is not associated with the lung. There's this gap. And because there's this gap between the chest wall and the lungs, then you can see that it's only on the right side that you get really good ventilation. The left side doesn't have good ventilation into that lung, and so you get kind of shunted. When the patient exhales, they get the opposite effect. It's like a balloon effect. So when you relax, basically it's, in this case, it's sucking the wall in. In this case, it's pushing the wall out. So flail chest is important because it reduces the surface area and the capacity for gas exchange. With pneumothorax, that's where you have a problem with the lung, the integrity of the lung wall to the chest wall. So there is an open pneumothorax, tension pneumothorax, we'll see spontaneous or primary and secondary. So when we look at these different pneumothorax conditions, if you work in the ER, you're going to see a lot of open, which is like a wound through the chest. So stab, gunshot. If a rib breaks from a bad fall and it pierces the lung, then that's going to be a pneumothorax. So in those cases, the patient can't fill that lung with air because there's a gap. With a tension pneumothorax, that's because of change in pressure within the walls of the lungs and the chest wall. Spontaneous and secondary. Spontaneous is when you have primary pneumothorax. I don't remember. Oh, hi Tyler, you just need time. What is a spontaneous pneumothorax example?
So spontaneous is when you have like if you have a weak spot in your lung or a rib puncture, like a broken rib, and it's whenever the air builds up inside the chest.
And so if you have a rib break that goes out one side and out and inside, that's an open pneumothorax.
Right. Or like a gunshot wound or stabbing or penetrating trauma.
And secondary pneumothorax is secondary to any type of disease that's going to cause the same thing, a weakening in the lung.
Which can cause or a spontaneous.
So is a rib open, a broken rib open, or spontaneous open?
So if you have a broken rib that protrudes on the outside, so you have like a compound rib fracture that's going to go in and out, then that would be open. If you just have a rib that's going inward and hasn't broken through the outer wall, then that would be just the
That's like all the way through the lung, right?
through. Yeah. So my understanding is that if the rib breaks, goes in this way and punctures, then that's a spontaneous.
Yeah, so spontaneous can also be like the typical demographic we see in spontaneous is like a tall, slender, white male. So like people who are runners that are really tall, typically see it there. It's most likely it's caused from like a weakening in the pleural membrane or in the lung that causes an exit of air from the lungs into the pleural cavity.
liquid. So in this case, transudative is when you have pressure that builds up and pushes fluid through the capillaries into the lungs. So there's a change in pressure there. With exudative, that's where you have fluid leaking through between the cells. So it's not pressure driven. That's the difference between those two. A hemothorax is associated basically with blood in the lungs. With empyema, this is when you have an infected pleural effusion. So the lungs, the fluid is usually clear, but if it's infected, then it's like pus. You normally associate with some type of an infection. Okay. And then chylothorax. Oh, I just looked that up. What was that?
Kyle. Chili.
Okay, I don't know. Cross it out. Oh, okay. Cross it out. That's how much you see it. Like, no, you gotta look it up. I remember. I'm gonna tell you, I told you don't have to know. I'm just gonna, for closure for myself. It's lymphatics. Lymphatic fluid gets into the lungs. Okay. But you don't see that very often because the lymphatics are not under a lot of high pressure. Okay. So with restricted lung diseases, you're looking at problems with either aspiration or problems with lung collapse or problems with the bronchi that are at lower levels of ventilation. You're talking about restriction of the ability to get air into and out of the lungs. So in this case, restricted lung diseases, aspiration, you get passage of fluid in solid particles. A good example of that is, of course, little kids when they aspirate. They don't chew their food all the way, and then they swallow it. Okay? With your geriatrics, you're going to see that a lot because they start to have problems with the swallowing mechanism. Okay? And then I think all of us have had fluid go down the wrong way one time, and so we've aspirated a bit of that. So unfortunately, we cough and have that. But you have to be very careful with your patients. And one of the things that isn't talked about, but is an issue, is if a patient takes in water, a substantial amount of water, but they cough it up, and so then they're like little kids, and then their parents don't bring them to the hospital to make sure that their lungs are clear. They can come up with different types of infections later because they have to be able to make sure that all that fluid is either cleared or they're getting an antibiotic in terms of infections. With atelectasis, that's collapse, lung collapse. And so there can be compression atelectasis. In that sense, something as you have mechanics who have the car fall on them, that would be bad. You can probably see a lot more of that with morbidly obese people, like my 600-pound man. Absorption atelectasis, you have, that's a problem with fluid and the lung collapses because you don't have a good enough change in pressure to open those lungs up. And surfactant impairment, remember surfactant is your natural detergent. And that natural detergent is important because your lungs, think of your lungs as a deflated balloon that you've blown up and then you let deflate and then you let those sides get together and they get very sticky. Okay? If there's surfactant in there, then you can blow the balloon up again, no problem. But if there's any problem with surfactant, then the sides of the lung walls get very sticky and it's very difficult to inflate the alveoli. With bronchiectasis, you have this abnormal dilation of the bronchi. And so, in this case, the problem is that they don't constrict, which is going to help move the air and change the pressure. So here's an example of absorption atelectasis. So in this case, you have low inspiratory volume, and the air is inspired, and you can see at this point there's this mucus plug. But in this particular case, there's this closed pore of cone, and this side is obviously deflated for the alveolus. In this side, it's normal. So when a person inspires with high respiratory volume, deep breathing, then what they do is they actually push that cone open, that pore open, so that they can get air in. But the problem is that they can't get the air back out because there's a mucus plug. So there's a problem with gas exchange because you can't get all the air out effectively. And in order to get full volume in the lungs, they have to deep breathe. Okay. And so if you've ever had a cold and you've had congestion and you've had to deep breathe, you know how exhausted your muscles get. So in this case, with deep breathing, these people have an added problem with their respiratory muscles getting fatigued. With bronchiolitis, you're looking at the bronchioli. So you have the trachea, and the primary bronchi, and secondary bronchi, and then those go into the bronchioli. So you get this decrease in volume, but an increase in the number of branches as it goes into the lungs. So in this case, this is, because it's got itis at the end, it's an inflammatory obstruction in those smaller airways. You see it primarily in children. You'll see it in your patients if they have chronic bronchitis, if they have a viral infection, a recurrent viral infection, or if they're in occupational hazard of toxic gas. So you'll see that often. And then with pulmonary fibrosis, what does fibrosis refer to?
Buildup of the collagen. Overproduction or buildup of the collagen, scar tissue.
Buildup of scar tissue. Okay? So you get this continued buildup of scar tissue that's taking really important real estate away from being able to inhale and get good volume. So there is this pulmonary fibrosis that occurs, and we don't know what causes it. So these are, this is inflammatory driven. This one is, we don't know what drives that. In this case, with inhalation disorders, mentioned toxic gases. When I was in high school, I was a lifeguard, and we had these huge vats of chlorine in the shed, and every couple of weeks the truck would come in and he'd put the big vats of chlorine in there in these big plastic 55-gallon drums, and then we had to have them filtered out to mix in a certain proportion with the pool water. I was working with a guy who wasn't the sharpest knife in the drawer, really good looking, not very sharp, had a great tan, and we were having problems with the chlorine. So he decided he's going to siphon the chlorine so it could start mixing with the pool water. And I said, I don't really think that's a very good idea. He's a long distance runner, so he was a tall white guy. So he starts doing that, and I went to the phone and stood there with the receiver in my hand ready to dial 911, which I had to do. And there was this big kerfuffle because we had all of and so he was fine, but So, don't inhale toxic gases and definitely don't siphon chlorine, gasoline, that kind of stuff. There's a little shed and these huge vats of chlorine. You walk by it and you're like,
Let's see how stupid I can be with that.
with pneumoconiosis, in this case, what happens is that you get these different particles. And you've heard of mesothelioma, commercials for that, or black lung from coal miners, okay, silica particles. So the problem is you get these minute particles and they go into the lungs and then your lung tissue encapsulates them. And they cause a reaction that increases the amount of fibrosis and fluid because you have all these minute little particles building up in your lungs and you lose the surface area for good exchange. With allergic alveolitis, in this case you have this extrinsic allergic alveolitis or hypersensitivity. So there's this reaction, anything, an allergic reaction is going to stimulate this hypersensitivity that's going to cause fluid buildup in the lungs. With pulmonary edema, that's straightforward, excess water in the lungs. In that case, the pulmonary edema can come, if you're talking about edema, you're usually talking about internal sources. All right. So we've talked a little bit about the importance of ventilation, and if there's a blockage of ventilation, we talked about perfusion and the ability to move that fluid air into the alveoli so you get good exchange of oxygen and carbon dioxide. We talked about different types of restrictive lung diseases with regards to inflammation-based or, in these particular cases, inhalation problems from outside of the body. This restrictive lung disease, this pulmonary edema comes from within the body. So if we look at acute lung injury, because a lot of what we talked about is not huge, well, pneumothorax. Okay. In this case, we're looking at an acute distress. And like a heart attack, if you have an acute problem in the lung, you know it right away, because it's immediately going to affect the ability to get oxygen. So there's this, with acute lung injury or acute respiratory distress, you have this acute lung inflammation, which means that it occurs over a very short period of time. So you get this buildup, and you can see in your kids or in your parents or patients that they come in and they have this problem with diffuse alveolar capillary injury. So what that means is that the alveoli are bathed in capillaries. There's blood all over your whole lungs, okay? Capillaries over your whole lungs. Surface area of your lungs is about the size of a tennis court if you put it out single cell. So it's a huge surface area. The whole thing is wrapped in these capillaries, and the ability for the capillaries and the alveoli to interact is critical for getting oxygen and carbon dioxide exchange. And with this, you have this problem with the interaction between the alveoli and the capillary. If there's inflammation, then basically you have a buildup of fluid between the capillary and the alveolus. And so that surface area now has been exponentially increased. So oxygen and carbon dioxide can't exchange well. So you have three phases to this. The first is exudative, and that's with this leaking of fluid in the cells, or between the cells. So fluid is getting between the cells and it's accumulating. And then proliferative, in this case, you have this increase in response to that because you're having cells proliferate to try to overcome this exudative response through the capillaries. And then one of the results of that is fibrosis because you have this proliferative phase, so the cells become more active, and then they lay down scar tissue or fibrotic tissue. So in each case, you're losing more and more lung capacity. The problem is, at some point, you don't get it back. So if you see somebody in the clinic with ALI or ARDS, you're looking at dyspnea and hypoxemia. So they're not breathing normally and they have low blood oxygen. They are hyperventilating. They may be in respiratory alkalosis. Do you guys have a measure for respiratory alkalosis they breathe into and you can?
We have to get ABT for that, but we can also get internal CO2 to help, but we're looking at ABT, arterial blood gas frequency.
So they have to measure it through a blood draw.
Right, so we can use ISTAT,
So unfortunately, they don't have anything yet you can breathe in.
not dying.
Only with alcohol. So, okay. So with, there's also a decreased tissue perfusion, which means that because you don't have this very good respiration and you have low oxygen in the blood, you're not going to get blood to the tissue, you're not going to get oxygen to the tissues. And a lot of the pressure that your body exerts for ventilation is going to help at some level with perfusion. So you get metabolic acidosis, which is different, which is opposite of respiratory alkalosis, right? Because this is in the lungs and then this is in the systemic blood. And then you're going to start to have problems with organ failure or organ dysfunction. So with the patients, they're going to work harder to breathe. They're going to have a decreased tidal volume, which is the amount of blood that's going to be exchanged over the course of a minute. They're going to have hypoventilation, and with hypoventilation you get hypercapnia, so they get an increase in carbon dioxide. Right? So this is basically looking at more and more severe problems as this condition is not addressed. So when you see a patient that has this, the diagnosis is based on the history of lung injury. It's going to be a physical exam, analysis of blood gases, and it'll be an x-ray. So they'll look at what the capacity in the lungs is there any black spots, how much fluid is in there. So it's just supportive therapy. All right. So with obstructive lung injuries, it's different from these are restricted. So what I told you so far has been restricted. You still get air in and out. Now we're going into obstructive. And with obstructive lung injuries, that's where you get an airway obstruction that's worse with expiration. So with restrictive, ventilation is impaired. It can be impaired either way, depending on where the occlusion is. With obstructive, you have symptoms like problems with breathing and wheezing. I think you're all familiar with these obstructive disorders: asthma, COPD, emphysema, and chronic bronchitis. So what you'll see a lot of them in your practice. You have to make sure that you understand the difference between if a patient is wheezing on the in or on the out. So with asthma, this is a chronic inflammatory disorder of the airways. And the inflammation is because of some type of an allergic response or hyper-responsive stimulation. So what happens is that the airways constrict, and you get what's called status asthmaticus. And people can die from this because you may not realize how severe the asthma attack is. So the symptoms, and this is important, they include wheezing upon expiration. So they breathe in, they don't wheeze. They breathe out, that's when you hear the characteristic wheeze. Okay? And like I said, go to YouTube and plug in these keywords because they're going to be really important for you to be able to identify these symptoms. Okay? Irregular breathing patterns or discomfort with breathing and fast, shallow breathing. Okay? So you can use flow meters, corticosteroids, beta agonists, and anti-inflammatories. My son was on Advair for many, many, many years and just inhaled Advair. There were a couple of times we had to go to the hospital and had to get nebulizers. So here you can see the problem are the mast cells, because the mast cells are going to shoot up small granules, and that's going to cause this inflammatory reaction. And so the smooth muscles that surround your bronchi are going to constrict. And that constriction is going to cause a problem with the ability to move air in and out because you get this mucus buildup. Because your lungs are lined with mucus, and your cilia are going to move the mucus all the time. And most of the time, the mucus is smooth and it's pretty fluid. It's not very viscous. When you get a cold, it gets sticky and thick, and you cough it up. You need to swallow it, but in this case, you get this mucus buildup, and then that blocks the air movement. And so, with this asthmatic response, basically what you're seeing is that you get some type of an antigen that causes this allergic reaction in the airway. And when that antigen gets in, then you have these dendritic cells that are going to cause this immune response, and the T cells are going to elicit mast cells to release granules. And when they release the granules, then that's going to cause this cascade of mucus buildup, because basically what it's trying to do is plug the airway from anything getting in. And so it becomes an over defense mechanism, or an extreme defense mechanism. So COPD is different. Chronic obstructive pulmonary disease is different because you have this persistent airflow limitation. If you know somebody who is a smoker, they have air purifiers they can wear. But my uncle was on a tether for like a 25-foot tether for years before he died because of smoking and COPD. And it's usually progressive, so it continues to get worse. This is key. It's the most common chronic lung disease in the world. So we're not just talking about the U.S., we're talking globally. And the risk factors are, as you would expect, tobacco smoke, but also different types of occupational hazards. If there are dust and chemicals that a person is exposed to continuously. Erin Brockovich is a pretty good example of that. Have you ever seen that movie? Air pollution. If you look at problems between different countries, China has a very, especially around Beijing and northern China, has really poor air quality, so that people walk around with masks often. So, and then anything during either development or childhood. So this demonstrates You get air movement during inspiration, and you have this mucus plug. During inspiration, you get the air moving in without a problem, okay? And why? Because when you inspire, or inhale, everything's opening up, okay? The chest walls are pulling, and the lungs and the alveoli and the bronchi, they're opening. So air going in is not a problem. Air moving out is the problem. Because at this point, the muscles are either recoiling, or if it's forced exhalation, they're actively contracting, and now that plug is blocking all the way across the bronchial passageway. So with chronic bronchitis, there's this hypersecreted, and make sure you know the difference between asthma and bronchitis. They're definitely not interchangeable. Asthma is a hyper response. With bronchitis, you get this hypersecretion of mucus and chronic productive cough. What's a productive cough?
Something that brings up.
Yes, you have something that comes up. With an unproductive cough, there's this coughing, but there's really not anything that's being brought up or released. So in this case, you get hypersecretion of mucus and this chronic productive cough, and this is key, that lasts for at least 3 months of the year. And it occurs at least 2 consecutive years. So what that means is somebody may have bronchitis 1 year because of something, and they never have it again. But if you have somebody who comes in and it seems to be going throughout the whole winter, and then they have it again the following winter, then they are identified as chronic bronchitis patients. The mucus is thicker than normal, but it can be treated by bronchodilators, expectorants, and there's chest physical therapy that helps to treat it. And so you're moving. The physical therapist is going to teach you how to breathe differently so that you can open those passageways as you. Now, emphysema is very different from the other ones because you have this abnormal permanent enlargement of these air exchange passageways, and you have destruction of the alveolar wall, but there's no fibrosis. The important thing about emphysema is this loss of elastic recoil. Because when you inhale, you have active inhalation. The diaphragm is going to contract, it's going to open this passageway up, and then when you exhale, you're relaxing those muscles, and because the lung wall is attached to the muscle wall, it's going to follow. The muscle wall is basically going to push the lungs together, and you exhale. And you don't have to work at it. So all of you right now are doing passive exhalation, and it's working. Okay? If you have emphysema, you can't exhale. You can inhale, you can inflate your lungs, but there's no recoil. So the problem is, with emphysema patients, they can't move the air out. Okay. So that's the end of obstructive lung diseases. So you get asthma, COPD, bronchitis, and emphysema. There's some type of an obstruction. In the emphysema portion, it's this loss of recoil and this buildup of, and no buildup of fibrosis. Yes? Loss of recoil is within the lung tissues, you have this elastic property. Okay? So you can Google cow lung experiment. It's amazing. Okay? Because what they do is they have these cow lungs in the lab, and they put a hose, basically a garden hose, and they push air in the cow lungs, and the lungs expand from about this big to about this big, and you're thinking, don't do any more. But when they release that, the recoil because of the types of proteins that make up the lung cause it to come back. Okay. So the problem is that the muscle wall may be fine. The recoil is gone, and there may be a loss of contact between the muscle wall and the lung as well. Okay? So when you look at a patient who has emphysema, you still have that ability to inhale and increase in pressure because there's no obstruction in, but you don't get help moving the air out. So the muscles have to be able to push the lung closed. So that means that people who have emphysema have active exhalation because the muscles are doing the work. And it's not very effective because your muscles are only going to be able to push air out a little bit. And if you think of geriatric patients who have arthritic problems, or you think of smokers who have degeneration of the connective tissues, then that becomes even worse. Good question. So, with infections, you're looking at some type of itis, something that's causing an itis. So in this particular case, acute bronchitis is just what the name implies. You have this upper respiratory tract infection that inflames the airways. So there's problems with air going in. So you say, I got an upper respiratory tract. Sore throat, problems with moving air in and out. And you delineate that from the lower respiratory tract infections because you don't have constriction with gas exchange once it's in there, but getting it in and out is problematic. And it usually follows a viral illness. With acute bronchitis, the symptoms are similar to pneumonia, but you don't have what's called pulmonary consolidation, which means that you get this buildup of fluid in the lungs. You don't get this loss of gas exchange area, or chest infiltrates. So any type of antigen, proteins, antibodies that are going to infiltrate into the lungs.
I have a question.
Yes.
So with acute bronchitis, if there's a severe case, could the doctor prescribe like an inhaler if like it's becoming hard to breathe, or is that something else? Because like I once had a very bad case of like bronchitis for short term, but after I had it, I found it harder to breathe. So like I had an inhaler for a while until I was fine.
I think
So-
so the question is, do inhalers help if you get acute bronchitis? I think within the case that you just described, probably what happened was that the inflammation was so severe, it took a while to repair the walls of your smooth muscle walls of your bronchi. And so the inhaler was helping to vasodilate that, and probably by having some type of a steroid and relaxing and reducing that inflammation until it could heal. Because you're not on it perpetually. So, okay, so with pneumonia, this is a lower respiratory tract infection. So bronchitis is upper, pneumonia is lower. And it can be caused by a number of different things. Bacteria, viruses, fungi, different types of parasites. It doesn't matter what causes it. The consequences, because we're limited in our responses, is the same. Okay? So whether it's a bacterial pneumonia or a viral pneumonia or a fungally driven pneumonia, it's going to cause this increase in lung consolidation and fluid in the lungs, and you will have infiltrates occurring. So you're going to have problems breathing and fluid collecting, and then they have to clear that. If you're in the hospital or you go to the hospital, depending on the severity, they have to clear the fluid out of the lungs. So in your case, if you're working in healthcare, that's it's associated with healthcare system. Okay, so the way they try to alleviate that in MRSA is you have some type of procedure done, and then they kick you out of the hospital. And then at that point, you're not their responsibility anymore. So people who have to stay in the hospital long term are at greater risk. And you can also Google different types of poorly sterilized equipment, like for MRSA infections or for pneumonia, pneumococcal infections. There are images of these instruments that have stuff growing on them, even though they've gone through an autoclave, which is over 121 degrees C, so theoretically they should be killed. With pneumonia, pneumococcal is the most common and most lethal. Okay? So if you're in microbiology, you probably already know that. Most common and most lethal. Because you get this intense inflammatory response. So once the bacteria infiltrates into the lungs, there's this immediate response to try to get it under control, which means your immune cells are going to try to get in there. And you're going to have leaky capillaries, you're going to have exudative fluid buildup, and then it's going to progress because now your lungs become an incubator for the bacteria. With viral, this is seasonal and it's self-limiting because a virus, unless it's going to kill you within a very short period of time, your immune response should mount and get it under control. And for the pneumonia, it's usually preceded by a viral upper respiratory tract infection. So, what generally happens is that your immune system is taxed, and so it allows for a secondary event occurring in the lower respiratory tract. So with other types of infections, tuberculosis. And tuberculosis is basically a very important one because it can be airborne. And for my international students in the lab, they get a tuberculosis vaccination, which means they test positive for it when they come into the United States. So you have a little tuberculin test, and it's subcutaneous, and then they see if you react to it. And so my international students have to say, we've had our tuberculosis vaccination. And they have to show that immunization. So, because when they test positive for it, if they don't have that to prove, they're immediately put in quarantine. Mostly you need to know that it's what the bacterium is, that it's airborne transmission, and you have this test for it. Now, abscess and cavitation are less common, I believe. Do you see a lot of that when you're working?
Not so much abscesses. We saw abscesses, just not full things.
So, we have T2 abscess, you gotta go to dentist. These are less common occurring. So if you have any type of cyst or fluid-filled cyst that's occurring, you're going to see that cavitation is this collapse, basically, and fluid-filled area in the lungs. consolidation is a buildup of fluid that we see as a consequence of pneumonia. So, I'm not too worried about those cavitation or consolidation or abscess because you're not going to see that. So, with pulmonary vascular disorders, you should be familiar with an embolism, right? An embolism comes off what? A blood clot. What's another word for a blood clot or something? Thrombus, right? Okay. So, it occur, oh yeah, there it is right there for you. Okay. An occlusion of the pulmonary vascular bed by thrombus. And so basically, if you decide to move to one of the coastlines, you may see more of pulmonary emboli that occur due to scuba diving problems. We see here in the water. But in this particular case, you can have an air bubble, you can have lipids, a tissue fragment, anything that's going to block a pulmonary vascular bed. Right? And the problem is that in many cases, it commonly arises from deep veins in the lower legs. So that's why they have this deep vein thrombosis, or peripheral vascular disease commercials now, so people can be more aware of it. And I think I don't know if I told you this story. My friend who's the extreme runner, one of those extreme 100-mile runners, and he's really big, tall white man. And he was on a plane. He was going to Colorado to run in this 100-mile run. Luckily, his wife is a surgeon, and so she goes with him. She doesn't run, and so he felt like his calf was really sore in the plane. And but he thought, I'm tall and you're in the Southwest and you have this much room, and so maybe that was the reason. But as he started running, his calf became more sore and started to become inflamed. And so his wife stopped him at a checkpoint and pulled him out, and they went to the hospital, and he was about this far from being dead because he had a deep vein thrombosis, and it had started to move, and I don't think it went to his pulmonary vascular bed. They got it before it got there, but it was on the way. So, and associated with this is the triad of Burkitt, which you should be familiar with, right? You got venous stenosis, hypercoagulable blood, so these people clot easily. Their injuries to the endothelial cells. Okay? So going back to what we're thinking about in terms of heart, you have, or circulation, the triad becomes important. So with pulmonary vascular diseases, you also have pulmonary artery hypertension. And with this hypertension, in your pulmonary circulation, remember I told you that you have very low tension through there because you have very delicate vessels. And those vessels, those capillaries, have to be able to exchange oxygen and carbon dioxide. So when you're looking at mean pulmonary arterial pressure, it's only 5 to 10 millimeters of mercury. So it's a very low number, okay? And if you see anything that's 20 millimeters of mercury or higher, then you're getting hypertension. With primary pulmonary hypertension, we don't know why. But you have diseases and hypoxemia that can make this secondary. Okay? So, because of either problems with low blood oxygen or problems with ventilation or problems with pressure, this can now become a secondary issue. So when you're looking at these pulmonary vascular disorders, you have arterial hypertension, venous hypertension, okay, depending on which type of vessel it's in. It could be due to respiratory disease or low blood oxygen. It could be due to a thrombus or an embolus, or it could be due to a disease of the pulmonary vasculature. So there's something actually wrong with the blood vessels within the pulmonary system. Okay, so these are the classifications that determine what type of pulmonary artery hypertension that patient has. So, with cor pulmonale, in this particular case, this person has has pulmonary heart disease and right ventricular enlargement. Remember we talked about that, and I think you had it. You might have had it for a content lab. Maybe that was a different class. Okay. So in this particular case, you get enlargement of the right ventricle because there's so much pressure that the right ventricle has to generate in order to move that blood into the lungs. It's usually secondary to pulmonary hypertension. And you have this pulmonary hypertension that creates this chronic pressure overload that causes that right ventricle to become hypertrophic. So it's a chronic condition. Obviously, because if it's acute, the person isn't going to live. All right. So, in terms of malignancies, do you have this? Cross it out. I'll talk about it in cancer. Okay. Cross this one out. Cross this one out. Okay, so now we're going to talk about kids. I have a few slides about children. So we're done with adults. You are not responsible, you can write this down, you're not responsible in this lecture for malignancies of the respiratory system. Any malignancies I want to go over, I'll go over in cancer. So, croup. Croup is acute laryngotracheal bronchitis. It's itis, so it's inflammation. You see this in children that are 6 months to 5 years, and it's commonly caused by a flu, a parainfluenza. Okay? And it causes edema just below the glottis. Okay, so you have the glottis. Below that, you start to get a buildup of fluid, and so they get this croupy cough. Usually in older children, you can see spasmodic, which is onset overnight. And I think the reason is the way that they're laying. They may have a buildup of fluid and they may have inflammation due to that. But with croup, you get this episode of rhinorrhea, which is runny nose. Some type of virus that's going to cause a runny nose. They get sore throat. They get a low-grade fever. They get what's called inspiratory stridor. So they have a problem breathing in. Okay? And they get a hoarse voice. So they have a seal-like bark. It's like, go to YouTube and Google it, because I'm not doing it. But it's sounds like a seal. But it's self-limited, because it's following rhinorrhea. Usually it resolves in 24 to 48 hours, but the problem is that parents are, oh my gosh, there's something so wrong with my child, and this incredibly terrible cough. And severe cases can be treated with a nebulizer. Tonsillitis is a lot more common, and it's you get tonsillitis that's secondary to group A strep, And be careful because when you're, you wanna wear your personal protective equipment when you're, examining the kids, because within the last 15 years or so, MRSA has, arisen. And so, you have to be careful when you're saying, say, and you're looking at what's happening with the tonsils. If a kid has, mononucleosis, of course, that can be transmitted. And, it can lead to an upper airway obstruction because the tonsils become so inflamed that they block inhalation. So, how many of you still have your tonsils? Yeah. Okay, I should have said, how many of us don't have our tonsils? Okay, so like maybe a quarter of us have no tonsils. Because now we know that the tonsils are really important for an immune response, but before then, I mean, every kid, we got tonsillitis, and then they were like, so I'm spending Thanksgiving watching the parade go by in the hospital because I had tonsillitis. Just give me the idea. So with bacterial tracheitis, this is the most common life-threatening upper airway infection in children. Bacterial tracheitis. It's associated with Staphylococcus aureus, influenza, hemophilus, or group A beta hemolytic spread. It's treatable. It's treatable. The problem is you gotta get it and bring the child to the doctor. So when we look at tonsillitis, it's okay, well, they get inflammation, they got a sore throat, they get a runny nose and drainage. Okay, but in this case, if it's depending on what the culprit is, it can be life-threatening. So what's a parent to do? Bring everybody to the clinic for everything. So, aspiration of foreign bodies. Kids put things in their mouth all the time and they choke. So, usually it's more frequent between ages 1 to 4. It doesn't have to go in their mouths, it can go through their noses. My grandson, I was having date night, we're really excited, we're at a friend's house, partying, having a great time, and get this phone call. Yes, why? Aiden put a corn kernel in his nose and we don't see it anymore. That's my grandson. I can't do that anymore. So I go home, get the monkey in the car, go to the emergency room, he's kicking and screaming the whole way. I have absolutely no pity for him. You go in there, the doctor puts the tube down, I have no pity. Sometimes put it down farther. Nothing. So he swallowed it, swallowed the corn kernel, didn't go down his trachea, but can. I'm glad he did it. He put a balloon in his nose and swallowed it. Did your mother ever see it again? No. So yeah, I'm sure that Tyler can tell you many interesting stories about aspirated ice house for children. Okay. All right. So the last thing is respiratory distress syndrome in newborns. So in this case, sorry, that was a mistake. Popcorn kernel. All right. I can't ever repeat that again. I know that. All right. So with newborns, it was previously known as hyaline membrane disease, and you get this poor lung construction, and there's an inadequate amount of surfactant. So you see this in preterm kids because if a baby it can develop past 20 weeks, they got a 70% chance of living because now they just can inject, and they can keep the baby incubated until the lungs develop. But, the problem is that in the preterm infants, you have this surfactant deficiency, and so you get lung collapse because the lungs get sticky, and that baby does not have the musculature to try to increase and cause that lung to inflame, and so they get hypoxemia. So that's why the doctors say, let the baby cry. It's really good for them because it opens their lungs up and it builds up the musculature and it clears it out. So if you have an infant that has RDS, then there's pulmonary hypertension because you get this shunting due to the ductus arteriosus not being fully closed. So, and you remember that we talked about different types of anatomical changes. So, or abnormalities. So in this case, you have fast breathing, there's expiratory grunting, there's nasal flaring. So you watch the infant, their nasal flares while they're inhaling, okay? And there will be blue. Okay, I'll just stop.